Our guest today, Dr. Barry Krakow, MD, is board certified in internal medicine and sleep medicine, and has worked in sleep research and clinical sleep medicine for more than 30 years. He's written a book titled Life Saving Sleep: New Horizons in Mental Health Treatment, and he's currently a professor of psychiatry and behavioral health in the Department of Psychiatry at Mercer University School of Medicine in Georgia. And I got to ask you, Dr. Krakow, how did an internist and sleep medicine doctor end up as a professor of psychiatry and behavioral health? Is it just like if you're a doctor for 30 years, you can just end up in any department? Because I have friends in med peds, and if I just work as a psychiatrist for 30 years, can I just go and take over their department? Because I'm so ready to do that.
Mine's much simpler. Once all of my friends and colleagues found out that I was crazy, they said, you should be a psychiatrist. But since I
Yes.
couldn't be a psychiatrist, they said, well, we'll just make you a professor of psychiatry instead.
Yeah.
That's one way. That's one way to keep an eye on you,
There
right?
you
That's one
go.
way to keep you closer and keep an eye on you.
Absolutely.
All right, let's start simple. All right. You're a sleep medicine doctor. Explain to people what the sleep cycle is and how it gets disrupted in some of the worst sleep disorders.
So I would reframe that question a little bit, because in the field of mental health, which is what through divine providence I ended up being involved in helping all of these mental health patients with sleep disorders dating back to 1988. I actually began my work with psychiatrists at the University of New Mexico Department of Psychiatry, and they were developing a treatment for chronic nightmares. So literally from 1988 to the present, all of my work has been working with mental health patients who have sleep disorders. And what we learned was that the sleep cycle, as you've put it, is highly disrupted and fragmented in these individuals. And it's such a big deal because, unfortunately, the mental health community, psychiatry, psychology, and other therapists, they're trained in a very different way to think about sleep. It's behavioral, it's neurotransmitters, it's psychological. It's something that you deal with by changing a behavior or giving a medication. And for this sleep cycle that you're talking about, where people have to go into various stages of sleep, eventually going into deep sleep, going into REM sleep, they never actually get to these stages because the cycle is so disrupted, not by the things that mental health professionals are trained to see. The actual, and we say this word in Hebrew, emes, the truth. The truth is that physiological things are the big player in mental health patients having sleep problems. And this is bringing psychiatry and psychology to a crossroads, which is going to be huge, in that they're going to have to decide, are they willing to actually deeply invest time, energy, and thought into understanding how these sleep problems actually work. So to actually answer your question seriously from the beginning, I've been developing a sleep program in the Department of Psychiatry and Behavioral Health over at Gateway Behavioral Health, which has its own psychiatry residency training program. So we're teaching psychiatry residents how to look at sleep very differently and not go down this pathway of thinking about its medications, its behavioral interventions. It's actually something deeply involved in the sleep fragmentation, the EEG. And to see that, you have to do what's called a sleep test. And once you do that, and once you gather that data, you learn very quickly. And this is what we learned in the early to mid 1990s, 30 years ago, that the largest number of people who walk in the door to a mental health facility who are saying, I can't sleep, usually have two things going on. One, they've tried multiple treatments for their sleep that don't work. And two, when they get sleep tested, they have sleep apnea.
Well, I'm glad you said all that because when I get patients, when I was trained, when people come in and they say they can't sleep, it's they say that as part of a mental health disorder, depression, anxiety. And if that doesn't fix, if the treatment for depression, anxiety doesn't fix their sleep, then they end up with all these kinds of sleep medications. At the time that I was trained, became Ambien. Then Ambien became Sonata. Sonata became Lunesta. Now they come in, they're already on all of those things. Now it's Belsomra, it's Dayvago. The Qvivic is now the new one. So I sent you a study that you saw that was done, I believe it was done recently. It was a huge review of all of the medications that are given for sleep, even ones that aren't sleep medicines necessarily, like trazodone. And there was no good recommendations. All of the recommendations were weak.
That's right.
So
why? Do you know why?
What do you make of that study?
No, it's brilliant. It's brilliant. It's like that's the problem. The reason the recommendations are weak is because the medications actually only work very well for select patients, and they do work sometimes for certain people. But they're weak because it's called begging the question. The premise of what they're doing is completely off. I'm saying there's a revolution going on in the field of sleep medicine, and we and a few others are some of the leaders. This was first discovered in 1973. 1973, somebody first discovered, Dr. Christian Guilleminault, the most famous recognized sleep researcher in the world until he passed in 2019. He recognized that sleep apnea was linked to insomnia. And so we carried on that research starting in the 1990s. We published more on it than anybody else on the planet. And it demonstrates, and the best example where we picked this up so quickly is that PTSD patients whose sleep problems are persisting and not responding to therapies, whether it's exposure therapy, whether it's medications, those people have between 80 and 90% chance of having sleep apnea. And this sleep apnea problem is destroying their sleep quality such that they don't go into delta sleep, or their REM sleep is fragmented. And everybody who's looking at them when you're sitting across the table from this PTSD patient treating them, you keep thinking, because you're trained, oh, it's psychological. Why didn't the exposure therapy work? Okay, well, let's use this medication. No, that's wrong. And we published a paper 10 years ago in Mayo Clinic Proceedings showing this. We had 1,200 people coming in to our facility in this chart review that we looked at, and 900 of them met a criteria called drug failure, meaning that they're trying to use drugs to treat insomnia. It didn't work. Of those 900 people, 860 of them had sleep disordered breathing, whether it was sleep apnea or upper airway resistance. And what I'm saying is this fragmentation is a physiological process that absolutely has to be tested for, diagnosed, and treated if you want that PTSD patient to get better. Because if that patient has PTSD and they have sleep apnea, the chances of them getting better are very low. And in fact, research has already been published by Dr. Christopher Rice out at Long Beach VA, showing if you just examine a group of PTSD patients getting exposure therapy, the PTSD patients with sleep apnea that are treated for sleep apnea, those are your responders. The people with untreated sleep apnea don't respond to exposure therapy. So this is a monumental shift that's going to be occurring in the field if people are willing to embrace it.
So when do you recommend getting a sleep study? When they come in, or do you recommend after they fail medications?
That's a great question, and it's why we're developing this program at Gateway Behavioral Health, where we want to try to put some type of sleep testing program into the actually residency program so that we can test immediately. Most of the people who have these problems could be diagnosed the first time they walk in the door to see you, the very first time. Now, that's actually unfortunate because the first time they come in to see you, they've probably already seen 10 other people. They've probably already tried 5 other treatments. So even before they saw you, they could have been tested. That's how early this could be done. That's how big a deal this is. Instead, what happens is people throw all the drugs at them for years. I've seen people on these drugs for 10, 20, 30, 40 years. Nobody ever asked them questions how to discern, well, could something physical be going on? It just isn't trained. So if you're not trained, how would you think to do that?
I get a lot of pushback because I suggest sleep studies all the time,
That's
but
great.
people just want their drugs. So how do you convince someone that they need this test? That now they have to go see a sleep medicine doctor, or they have to do work now to go find a neurologist or pulmonologist. I'm not just going to give you your Ambien anymore. You've got to go do work and go, because this requires them to put an effort now.
Yeah,
Which may delay it even more in their eyes, because sometimes to get appointments with some of these specialists, it's
Especially
a
in
couple
this
of
area.
months,
Yeah,
3
it's probably
months out,
months,
whatever
yes.
it is. Some is 6 months.
So at the risk of sounding overly self-serving, they could just buy life-saving sleep and they could read all about it and they would go, oh, wow, I see where I need to go. So the point you're making is a very interesting one, which I believe can be turned around in favor of a different point of view regarding patient care, which is this. How many patients in psychiatry who have depression love to hear that they have a thyroid problem and that the thyroid problem is causing the depression? And they're not really depressed.
It's not very many.
No, it's very rare.
No, I know that. But what I'm saying is, think about that patient's mindset.
Right. It sounds a bit dismissive. Right.
And so if you tell somebody, by the way, your PTSD is not just because you were traumatized. You don't have just all these mental health things going on. You have something physical that is going on with your body. It is actually causing brain damage. And that brain damage is making everything worse. And there's something you can do about that. And yes, it takes some extra effort and time and so forth. But for a person to hear that something physical and physiological is wrong with them, that's usually music to their ears if they've been told for a long time, oh no, you're just nuts.
And it's
You're just
in
crazy.
their head and whatever it
Right.
is. Mhm.
Yeah.
Right.
You know, and
Wait,
it's
you have a question. Go ahead.
and it's interesting too, because in reading your book, you talked about post-traumatic stress disorder and the nightmares that are associated with post-traumatic stress disorder, which is one of very common symptom of PTSD. And you talk about image rehearsal therapy, and in essence, helping that person unlearn those nightmares as well. So I think between that, which is one of the common symptoms coupled with PTSD, as well as the sleep disturbances, which in part are they get up from the nightmares, whatever it is.
Right.
What are the success rates in treating both the sleep disorder, whatever's the physical cause of the sleep disturbance, and the IRT?
Well, it's funny you ask the question that way, because most people never think to ask it that way. We know from our research, and this is not published research, this is just clinical experience, and worldwide people know this, that IRT still works when people have sleep apnea, which is remarkable. But it really does work as an imagery, changing process. So the human mind is capable of making that and actually getting benefit. What's proven more fascinating over the last 20 years is that we now know, and there's about 9 research papers in the scientific literature today showing that if you treat sleep apnea, your nightmares get better. So 9 different research papers out there all showing the same thing. Using a CPAP machine will make that better. And coming back to your point about post-traumatic stress, what we're getting at here is, yes, there are psychological components, for example, nightmares and insomnia. But all of this is like top heavy with sleep disorders, nightmares, insomnia, sleep disorder breathing. Many PTSD patients have restless legs and leg jerks. So, and not to mention your earlier question about circadian rhythm cycles. So all that is going on and not being addressed. It's just not being addressed. People are not saying, well, I see you have these independent disorders. And this goes back to a very interesting paradigm in the DSM. If you follow the DSM through the years, eventually, by the time they got to DSM-4 TR, they began writing how sleep disorders might actually be independent, even though most of the papers published all the way up to, say, 2010, if not to the present, still talk about sleep as if it's a disturbance. And what does that mean? Well, if it's a disturbance, that means it's a secondary problem. It's not the primary problem. Oh, so just keep giving drugs. And what we've been preaching now for quite a while is no, these are independent, primary, co-occurring, comorbid conditions. And you have got to pick and target each one. Nightmares, insomnia, sleep apnea, restless legs, leg jerks. And this is why I say psychiatry and psychology are coming to a crossroads, because they have to be able to say, well, wait a second, if we're missing this, are we just going to send them over to sleep doctors? Why don't we do it? You know, here's a very interesting paradigm to consider. The single biggest group of doctors in the world who are embracing this comorbidity model is cardiologists. Cardiologists are now advancing their own sleep medicine programs inside of cardiology. What we're doing here at Gateway Behavioral Health is we're training psychiatry residents to stop picking up the prescription pad and looking at their patient's throat and finding out, hey, you know what? That's a crowded throat. Let's talk some more about what's going on with your symptoms. They're going to be coming out into practice. And eventually, I believe psychiatry residency training programs all over the country are going to be forced to adopt this. And if they don't, I think it's going to create huge problems in the field of mental health.
Is this a purely American problem, or is this kind of
absolutely global, all over?
So
I just did 3 Zoom training seminars for mental health professionals in Israel. They're obviously dealing with tons of PTSD, nightmares, and insomnia. And this was brand new. Again, brand new, that when I talked about the nightmares, we talked about IRT. When we talked about insomnia, we talked about cognitive behavioral therapy for insomnia and emotional processing techniques. And then when we talked about sleep quality and sleep fragmentation and sleep disordered breathing, it was like, wow, you're saying like all of these patients could be having this problem? Not all, but when people don't recover, when they're not doing well with their PTSD treatment, it's a huge red flag that something physical is going on.
Yeah, no, we've been talking, and I think a few times all of us mentioned that or realized that these patients, I'm going to speak for the bulk that get what we call resistant insomnia. They get bounced around from specialist to specialist. In my experience, I'm sure Dimitri has had the same experience. We often receive patients that have tried, and they tell you, I've seen X amount of number of sleep specialists, I've seen other doctors, and then they all say, go to a psychiatrist. Then we work with them for a few weeks and months, right, and we say, we can help you go back to a sleep specialist. And then there's one diagnosis I've come across, and I don't know how to tell a patient without them being a little bit disconcerted, and is the so-called sleep misperception, or now it's called, I guess it evolved to paradoxical insomnia, meaning basically you're telling the patient that we've done testing, your sleep apnea test has no objective findings for your insomnia, and it's mostly that you've been dependent on medication. So how do you explain your patients that they are sleeping but they don't know they're not sleeping?
Right. So this is a great set of circumstances you've just set the table with, because this is the problem you're describing. You may not even know how big the problem is that you just described, because you brought up so many different things showing how the system is broken. First of all, most people who are sleep doctors that try to test for some of these different things, who would come up with a diagnosis of sleep state misperception, the chances are 90% they're wrong. Absolutely wrong. And why is that? Because what's happening And I've seen tons of people who have been either labeled that way or told, well, it's just in your head and all that. What's happening is when you have really bad sleep fragmentation, you're going in and out of stage 1 sleep constantly through much of the night. Well, I could take any person in this room that we're talking in right now. You could take any of your patients. If you fragment their sleep that way, you're going to start saying, I didn't sleep last night. Well, oh, I'm sorry, I've got an EEG here. It says you slept last night. That's bogus. It's absolutely bogus. So that person does have a perception of very broken sleep. And they have learned, for unfortunate reasons, maybe because of anxiety sensitivity, that would be a good explanation, to interpret it that they're not sleeping. Well, they're not sleeping well, so give them credit and let's go find a better sleep doctor who actually knows how to understand why that sleep is fragmented. And you probably have heard from some sleep tester, specialists, oh, they just had some spontaneous arousals. They just wake up for some reason. We don't really know what it is. Sleep doctors have been doing this for decades. The predominant sleep doctor is what? A pulmonologist. They're not necessarily interested in this paradigm. And Dr. Guilleminault figured this out with a condition called upper airway resistance syndrome, which is a variation of sleep apnea. It's much more subtle. It's much more difficult to detect. Only about 1 out of 3 sleep doctors are interested in looking for this subtle breathing condition and diagnosing it. So when you describe, Steph, that kind of set of encounters, that's incredibly common. And these people are horribly frustrated. They go, I went to the sleep doctor and this doctor said, well, you don't even need a test. That's number one. They still do that. Oh, no, you don't even need a test. Then when they do the test, they go, oh, you may have some mild sleep apnea. You're fine. Go away. Don't sleep on your back. It's a horrible, horrible thing that is going on because these people have these conditions that have a physical explanation, and it is the responsibility of the sleep doctor to say, look, I'm not exactly sure how bad your mild sleep apnea is, because the truth of the matter is sleep medicine isn't very good at measuring sleep disordered breathing. Those metrics are not very reliable. And so what you find in the better sleep doctors is something very simple. They go, you know what? You deserve a chance to try a PAP machine. Let's have you try a PAP machine and see what you feel. Because if you start to feel better, then we know we've hit the jackpot, and this is a really important issue for you, with one caveat. And that big caveat is that so many people fail CPAP. And so that's why we switched 20 years ago, and we only put our patients on these more advanced PAP machines called bilevel, auto bilevel ASV, which people are able to use and actually have good outcomes.
What's the difference between upper airway respiratory syndrome and sleep apnea?
So in sleep apnea, we think of the concept of breathing event type. So if you stop breathing, that's pretty obvious. So you call that sleep apnea. Your oxygen drops big time. The second category is called the hypopnea, where you probably lose about 50% of the volume of your breath. So that's still, very important and can also be associated with oxygen changes. But what Dr. Guilleminault discovered years ago, he first discovered it in 82 with children, and then again in 91 with adults, is that you can lose between 10 and 25% of volume of your breath, and that will trigger an arousal in your brain. Not only that, he proved that that condition alone leads to high blood pressure, and it leads to trips to the bathroom at night. So all sleep apnea patients are at risk for high blood pressure, and all sleep apnea patients are at risk for having excessive trips to the bathroom at night. So he discovered this, and this very subtle breathing event is the one that only about 1 out of 3 sleep doctors seems to be interested in. And so when you're sending patients to sleep specialists, you want to ask the question, so do you diagnose upper airway resistance syndrome? Do you treat upper airway resistance? Because in our clinical experience, most of our patients, the vast majority, have some apneas and hypopneas, and then they have a lot more of these upper airway resistance events. The combination of the two usually makes these people have moderate to severe sleep disordered breathing. And that's, I think, why it's such a big deal.
You mentioned the urination thing, and I listened to your TED talk on that, and you said that obstructive sleep apnea can cause urination. I wanted to show you something. Do you know who Andrew Huberman is?
Mm-hmm.
Okay, he's a neuroscientist at Stanford, an associate professor.
Sure.
He has a podcast.
Right.
I don't know if you listen to that or anything like
I
that.
saw his recent podcast a couple of months ago about nocturia, and he did not explain the relationship unless you know of another podcast.
No, but actually, I want to play that because you're talking exactly about that. But he has a 5-minute clip on that. I cut it down to about 2.5 minutes. You've probably seen it, but I want to play it for the audience, and then I want you to give your take on it. Okay?
Sure thing.
You need about 8 ounces or 240 milliliters of fluid per hour for the first 10 hours of your day after waking. Now, why did I say for the first 10 hours? Well, it turns out that the filtration of fluids from your body, which is accomplished, of course, by your kidneys and by way of your bladder and the excretion of fluid out your urethra, so-called urination, is strongly, strongly circadian dependent. And we can make all of this very simple by simply stating what's contained in this beautiful review that I'll provide a link to if you want to learn more, called Circadian Rhythms in the Kidney. And basically what is known is that for the first 10 hours after waking, your kidney is filtering fluid within your body at a very rapid rate. However, at about 10 hours after waking, your kidney really starts to reduce its overall level of functioning. Now, that doesn't mean that your kidney cannot filter fluid 11 or 12 or 16 hours after waking, but it becomes far less efficient at doing so. And thank goodness it does, because you do not want your kidney filtering fluid at the same rate at midnight that it was filtering fluid at 10 a.m. In fact, we can say that if you want to reduce your nighttime waking in order to urinate, and there I say it's perfectly normal to wake up once, maybe twice each night to urinate, but if you want to reduce the number of times that you wake up in order to urinate across the night, maybe even make that number 0 times, you will greatly benefit by doing 3 things. First of all, make sure that you're hydrating sufficiently during the daytime. That will ensure that you are not excessively thirsty in the evening and therefore consuming a lot more fluid. Second, and related to that first point, is that you do want to reduce your fluid intake at night, provided you hydrated sufficiently throughout the day. And believe it or not, the rate at which fluid moves from your gut and into the cells and tissues of your body, and then from your bladder into urine, is determined not just by the volume of fluid you ingest, but also the rate at which you ingest that fluid. So here's what I recommend. Throughout the day, when you're trying to get your adequate yield of water or other beverages, feel free to gulp that fluid or sip it. In the evening, if you are somebody who has challenges with waking up excessively in the middle of the night, reduce your fluid intake, provided you've hydrated properly throughout the day. And I suggest consuming no more than 5, maybe 8 ounces of fluid between the time of 10 hours after waking and when you go to sleep.
So what do you make of that?
There's points there that may be accurate, but this is not a complete story. So let me ask you this question. If I put somebody on a PAP machine who is urinating 4 times a night, or twice a night, or once a night, and they report after a week or 2, they no longer have trips to the bathroom, what then is normal trips to the bathroom? The scientific literature, unfortunately, and the lay media, unfortunately, continue to believe that 1 to 2 trips to the bathroom at night is normal. Sleep medicine argues differently because we have a pathophysiology far more advanced than what was described there to explain why you wake up to pee. This also doesn't explain why I actually would prefer to be hydrated during the night. And so in my own experimentation, I can drink as much as 32 ounces of fluid within 1 hour of going to sleep and not wake up to pee. And so this pathophysiology that he did not mention, I believe, would be a more complete picture to draw. And it's very specific. You know, when you have increased chest cavity pressure, increasingly negative intrathoracic pressure because you're trying to breathe from sleep apnea, you're pushing too much blood too rapidly into the right atrium, and the right atrium either figuratively or literally is distending because it feels there is excess blood, excess flow. The right atrium of the heart has its own diuretic, ANP, atrial natriuretic peptide. Studies have been done proving all of this. The diuretic, the amount of urine, all of this stuff has been proven over 30 years ago. So what does that diuretic do? It goes to the kidneys during the night, and you start waking up to pee more times. What does sleep apnea treatment do? You could do a dental device. You could do a PAP machine. I actually know some people who've used nasal strips and said they've had some reduction in their trips to the bathroom. So that pathophysiology is completely reversed. You do no longer have the chest cavity pressure building up, pushing excess blood into the right atrium, so the right atrium does not release a diuretic. It's astonishing how many sleep doctors know this and how many other doctors don't. Some urologists are beginning to catch on. Some cardiologists definitely are catching on. But it's very common for people to be espousing this idea that 1 to 2 trips to the bathroom at night is normal. And I would say, okay, well, if it's normal, what would you say if it went away by using a PAP machine? Would you still say the 1 to 2 is normal? Or would you say, hey, I think normal might be 0 and I like 0?
But if it's been 30 years now, why isn't anybody recommending this stuff then? Shouldn't everybody be on a PAP machine then?
Well, that's its own interesting question. Like the rate of sleep disordered breathing in society is getting worse for lots of different reasons. One would be not surprising if you say that weight is increasing,
right?
But obesity doesn't cause sleep apnea. People are very confused by that. Obesity worsens sleep apnea. The cause of sleep apnea is where you breathe. It's your throat. And so if you look at facial structures and the way people are growing their heads, so to speak, whether they're breastfed or not breastfed, whether they're malnourished or not malnourished, we're probably seeing a lot of changes in head craniofacial structure that then create risks for having more narrow airways. And so that's why, in part, we're having a bit of an epidemic of sleep disordered breathing.
Hang on a second. Are you saying we're evolving to sleep apnea?
It appears that the way, let's put it like this.
That's a hot take.
Oh yeah, if you say that the longer the longer you keep people alive, are they going to get more diseases? Everybody would agree with that. Nobody's saying, oh yeah, that's not a surprise. This may fit into that pattern. I don't know, but we do know that craniofacial, it seems, there's many people who've written about this even 20, 30 years ago. Dentists, oral surgeons have written about this exact topic, that facial structures seem to be changing and that could be creating a big risk for sleep disordered breathing in the population, especially Western civilization.
But OSA comes about when you're young too, so it's not an elderly disease.
It's a disease of all age groups.
Correct. So
it doesn't mean that you just get it when you're a kid and then that's it. You could absolutely not have it as a child or a teenager and get it later for a number of reasons. What if the airway muscles in your throat weaken for some reason? That could be aging. What if they weaken because you put too much pressure on your neck because you've gained too much weight? What if there's something to do with fitness? And that has to do with the way your muscle integrity again in your airway is maintained.
So it's not just an evolutionary thing, it's a societal difference. The way we exercise, the way we eat, the way
It,
we sit on the couch too much,
it
deconditioning.
it could be, but the big one I'm getting at is that if your airway structure is such that you were cursed as opposed to blessed when you were born, and you don't develop that airway structure to expand the upper airway, and that is an absolute risk for getting sleep disorder breathing. That doesn't mean there can't be somebody who has a narrow airway that doesn't get sleep apnea. We're not saying it's a one-to-one correlation, but there are so many children, for example, think about all these babies who have sleep problems, and everybody thinks it's behavioral. And they think, oh, my kid just won't settle. Why would a 6-month-old settle if they can't breathe? They're tossing and turning and getting up because they can't deal with this. They don't have a conscious awareness of it. They're struggling to actually breathe better. So they're turning around, they're flopping around, they're trying to figure out what they can do to breathe. And we're looking at them like, oh, well, you've got this behavioral problem. Oh, you're co-parenting, you're co-sleeping, you're doing all this stuff. I mean, again, this physical factor is it's the, what do you call it? It's the gorilla in the room. It's the 800-pound gorilla. It is diabolically involved in so many aspects of healthcare. It appears unbelievable.
Yeah.
But
And you
ahead.
bring something interesting up too about children and sleep and the 6-month-old not settling. And we see, we hear about children older than 6 months, obviously, 2, 3, 4 elementary school age children having sleep disturbances as well, where their parents say they won't go to sleep, they won't settle down. I can't get them to sleep at night. What is your take on the role of things like electronics and children sitting there on their iPads
Right.
for hours, let's say, or playing video games before they're going to bed?
Right.
How does, in your research or in your experience, how does that affect
Right.
their sleep?
It's a highly relevant factor, but it's also a red herring. It also comes back to, and I love the word because I learned this in psychiatry, perseverating. I'm going to perseverate on physiological sleep disturbances. Why is that kid looking at the screen? It's not just to be entertained. It's that they can't settle. And they're going to go, well, I can't settle my mind. Okay, now here's a big one that we published years ago. It's called the Respiratory Threat Matrix of Chronic Insomnia. And we have no way to prove this, because I don't know if there is a way to prove it. But we've asked so many patients about this phenomena, and they've all said the exact same thing, so I'll just spell it out. We have seen patients with insomnia, with racing thoughts, troubled mind, can't turn off the engine. They got no other treatment but what? A PAP machine. They started using a PAP machine, and suddenly they didn't have racing thoughts. How is that possible? And I think the answer is the racing thoughts were used to keep the person awake. Why? Because even if you lose 10 or 25% of your air volume, that's 10 to 25% of mini suffocation occurring hundreds of times during the night. Why would anybody in their right mind go to sleep?
And
Sleep
Right.
is stay awake. Stay awake and you won't choke. Stay
So-
awake and you won't suffocate.
So I'm glad we're talking about wake and racing thought. It seems to me, correct me if I'm wrong. Yeah, I don't know how long we've been studying this side of things, but it seems to me the new advent medications that are on the market, the fancier names, attack the orexin, physiology, and they talk about suppressing the wakefulness instead of focusing so much on sleep architecture, if you will. In your experience, in your research, how much is involved into the sleeping schedule when we focus a little bit more, let's say, on wakefulness, shutting down that wakefulness of the brain, so to speak.
It's a very important area, and I agree with your thesis that, you know, if you look at the problem that way, instead of I'm putting you to sleep, I'm helping you lower your level of alertness. But again, because I like to, you know, play the role of a psychiatrist, even though I'm not one, I have delved into this in so many different ways. And the way I first learned about this, even before I got into the whole physiology part, was that there are very advanced emotional processing techniques that you can train a patient in that will absolutely dissipate racing thoughts. Because what are racing thoughts? Racing thoughts are unfinished business. And what is unfinished business? Unfinished business is the emotional residue from the day that you never really spent the quality time you needed to work through the problem and get to at least some little bit of closure. And that is the good news, by the way, about emotional processing in treating insomnia. It's not like you have to go through, what's it called, abreaction and catharsis to get there, but you do learn to tamp down some of your racing thoughts by working on your emotions. And when you explain this to people, they go, well, some people have been doing it so long, they don't know what emotions are. Many insomniacs live up here in their head, and they have a very difficult time understanding the concept. But once you work with them and they learn that their anxiety, their depression at times are really covers for deeper emotions like anger, shame, embarrassment, guilt, and so forth, and they begin to work on that, then their mind starts to slow down more because they are working in their heart, learning to listen to their heart, and that process, you know, treats racing thoughts. So I purposely went down that pathway for you because I rarely, if ever, prescribe a pill for somebody to go to sleep. It's more people are coming to me saying, doctor, can you help me get off these pills? And I say, yes, I can. I actually have a coaching service at my website, barrykrakowmd.com, and I help people with that. But I explain very candidly, once you're on these pills, you can't just get off of them quickly. You've really got to work through various steps. And of course, the great news for the large majority, if they're diagnosed with sleep apnea and they can get on a treatment for sleep apnea, that's going to make getting off a sleeping pill so much easier and a shorter time span compared to somebody who's just trying to do cold turkey and drive themselves nuts.
All right, Dr. Krakow, we're never going to get to every question, so we're going to have to get you out on these last two.
Sure.
In your book, you do go into the business of PAP machines and insurances. And as someone who's gone on many insurance and medical business rants, I'm going to give you the platform to go on a rant here on, if you'd like, on how these insurances kneecap doctors and patients when it comes to PAP machines, if you want to.
That's a great question because, again, it's a big part of the problem. You all are at a place, I'm sure, just as almost every psychiatrist and psychologist I've met over the last decade, you've been at a place where you've heard about people not having a good experience with a DME company for their CPAP, not having a good experience with a sleep center. Then you heard about how the insurance company got involved and said, well, they're taking the PAP machine away. This is absolutely a bureaucratic nightmare. And there is no easy answer to it because everybody listens to Medicare, and Medicare creates these rules about you've got to use your machine X number of days for X number of hours. And, you know, that is highly relevant to many patients who have that capacity. But when you're talking about mental health patients and you're saying, here, slap this thing on your face. I don't care about your claustrophobia. I don't care about your panic attacks. Oh, you have claustrophobia? You have panic? Oh, well, I mean, this is a huge issue, and the insurance companies, they're not paying attention to that. And so what happens is we say we're going to gradually introduce this person to PAP. So that's the secret that sleep doctors have learned in working with people who have these problems like claustrophobia and panic. And usually you can negotiate with the insurance companies to let the time drag on for a long time if the sleep doctor knows how to do that. So there is that caveat. You can make it go on for a long period of time. The sad part is that the insurance companies and many sleep doctors think that CPAP, which is continuous pressure, works for everybody, when in fact that's not true. And the bi-level devices that give different pressures, breathe in higher, breathe out lower, you end up with a much more comfortable experience, and that's why people adapt and use it. So that would be my insurance rant.
Okay. All right. Well, we're going to get you out on this one. You've worked with internists, you've worked with sleep doctors, you work with psychiatrists. Be honest. The psychiatrists are much more fun, right? That's the truth.
There is no question. There is no question working with mental health professionals is not only more fun, but I have to say that over the years, you all have been the one that have been interested in sleep. So it surprised me that it hasn't taken off faster in the field of internal medicine, family medicine, primary care. It's more like, okay, send them to the sleep doctors and so forth. But you guys have so much interest in sleep, even if, you know, the training you got wasn't as complete as I would have liked to have seen. But it is no question that it's been so much more engaging. And I'm hoping one day when I'm like 120, I'll get that honorary degree and they'll say, oh, this guy's a real psychiatrist.
No. We're doing it now. No. Right now, we're bestowing upon you, Dr. Barry Krakow. The Psych Effect podcast has bestowed upon you an honorary degree, an honorary board certification from the Psych Effect podcast as a psychiatrist.
Where's my plaque? You need a plaque, man.
It's right here. It's going to be on the screen. We're going to put it on the screen. Your plaque. That's right. We're gonna put it on the screen here for you on YouTube. And there's no way we're going to get to all the questions. We're going to have you back at some point to talk more sleep, because this is I think
big topic.
I mean, I see so many people a week, and I think probably 80% of them have a sleep complaint of some problem. So we're gonna have to bring you back. I hope we can consider you a friend of the show. Absolutely. And thank you very much for coming on.
Thank you so much.
And we will have you back on the show. Thank you again.
Have a good day.
All right.
Thank you. You too. Bye.
Bye.